Let me put this up. Maybe this is okay. Yeah. So basically, what I'm going to talk is first, which are the things that you're going to take a look at. So many cardiologists will tell you different ways in which they like to go through an EKG. The most important thing is that once you basically start doing it one way, you will start doing it always the same way. The reason why it's important to always have the same schematic is because that way you're not going to run through things too quickly and jump to conclusions before taking a look at every single thing in the EKG. So the first times is going to take you longer, but then little by little you'll see how it gets faster. Okay, so the way that I see an EKG, I take a look at a total of kind of 16 things. Okay, so the first thing that I'm going to tell you is who is my patient? So that's the most important question actually, because that will, in general, it might give you bias, but at the same time, it tells you what's the baseline of the patient, what you're going to look for, right? It's not the same to have a patient who's coming to your clinic for an annual physical than a patient is coming to the ED in the setting of acute chest pain, right? So by who is my patient, I don't mean like doing a full HPI. You just need like a one-liner in which you need at least the age, the sex, and the chief complaint of the patient, okay? So that you keep that into to the back of your mind when you're reading. Afterwards, what I look at is the standardization, right? So the standardization is in the, we'll see it, but it's in the left bottom part of the EKGs in this institution, at least the majority as well. So you'll see the paper speed and the voltage, right? The paper speed is 25 millimeters per second, and the voltage should be usually 10 millimeters per millivolt, okay? So why is this important? Because every single conclusion that you take, including the heart rate, is depending on that standardization. So if for some reason somebody changed the setting of the EKG machine and just place the trace in that way, then it's going to be completely different than what you would see in the usual 25 and 10, okay? So always take a look at that. The third thing that I do is to take a look if this is actually well taken, meaning are the leads placed where the leads should be, okay? So for that, so well taken EKG. For that, you need to look at leads 1, 2, and AVR, okay? Think about the P waves, okay? So 1 and 2, P waves will be positive, and then AVR, you're going to see negative P waves and T waves, okay? Very important, because if you, again, if you, there might be some exceptions, obviously, like in wide complex tachycardia, but in general, in a patient who is not in a wide complex tachycardia, this should be the case for you to say it's well taken and I can analyze it, okay? Once you know already that who's your patient, is the EKG well taken and well standardized, then you start jumping into the other stuff, okay? So next thing I think is the most important will be the rhythm, okay? Rhythm might be tricky, and I think you discussed that with Luca already a little bit, but it's not always only one rhythm going, right? Sometimes the AHI can go at a pace that is going different than the ventricle, okay? So we'll discuss that, but in general, today we're gonna focus on normal EKG, so we're gonna talk about normal sinus rhythm, okay? But rhythm, and then rate, we'll go through here the 3 different ways that you can measure the heart rate, but I'm sure that he also covered that already, okay? So after talking about that, then you can start, you can go with axis, you can do whichever thing you want. I'll show you what's my actual schematic, but afterwards I just go wave by wave and segment by segment, okay? So I'll start with P waves, then PR interval, PR segment, and you'll see how in each one of these ones you can find many things that will tell you how important a little piece of paper of 10 seconds can actually give you so much information. But the last step, the one that I consider the 16th step, would be basically comparing with the prior EKG, okay? That is very important. So we'll jump back and forth from the lecture to this, but let me just show you something first here. So this is what we were going through right now. So as I'm saying here, it's the most important slide, right? Why is it the most important one? Because once you, as long as you have all these things in your uh, stepwise approach and you always cover it, then you won't miss stuff. Okay, at least 90% of the time you'll be correct just by always doing the same order. Okay, it doesn't have to be this order, but it has to cover all these things. Okay, so let me just run through a little bit of these things before we jump back the whiteboard, because if not, you won't have it in the back of your mind. So lead placement, I'm sure he also spoke about, but I just want you to notice that
Excuse me, Roberto.
every single current goes from negative to positive, right? So if you see lead 2, which as you know is 60 degrees in your, when you see it this way, is at 60 degrees, it's always, the current always goes from negative to positive. So basically the current goes from the right arm to the left leg lead that you place, okay? Now, standardization, I spoke to you about the speed of the paper is very important. So 25 millimeters per second. And then your voltage is going to be 10 millimeters per millivolt. Okay.
I think they can't see the EKG.
Then the heart rate calculation. So the heart rate, there are 3 ways.
Roberto,
Yeah,
we still just see the Surface whiteboard screen.
So share screen again. You share. You don't listen. You share.
Here. Sorry about that. Let me see. So I was talking here that this was the most important slide.
Perfect.
So these 16 things are the things that I was saying that you should cover independently of whichever is your order. As long as you cover it, it should be fine. And in 90% of the cases, you will be correct. So we were talking about at that point QRS axis, and then we were going to talk about the waves and the segments all in order, at least. And the last step is comparing with the previous EKG. I was talking about the lead placement here, and I was just pointing as an example, lead 2. Lead 2, as you know, is at 60 degrees, and you can see how it goes from the negative current to the positive. Okay, so it's always going from negative to positive, and that's how it goes to 60 degrees. And you can see with all the other ones, for example, lead 3, which is at 120 degrees, so from negative in left arm to positive in the lower extremity. Okay, this is just talking about the paper speed and the voltage. I was telling you that the normal and the way that you would have to read it is when the EKG is taken at 25 millimeters per second and with voltage of 10 millimeters per millivolt. Okay, so when you have these ones, then you can say that one small box is 40 milliseconds and one big box is 200 milliseconds. The same applies for the voltage, in which case one small square is only 0.1 millivolts and one large one would be 0.5 millivolts, okay? The other way that you can see it in the EKG, if somebody gives you an EKG without these ones, at least you can see the voltage based on this big box at the beginning. So this rectangle actually will tell you how much is 1 millivolt, okay? So it should always be 10 millimeters, so 2 big boxes, okay? Heart rate calculation, as you already covered before, I'm just going to give you the 3 formulas that there are. So you can do the count of method, right? So one big box is 300 beats per minute, 2, 150, and so on. So it's basically 300 divided by the number of large squares that you have. Meanwhile, the one that is the best one or the most accurate one, as long as it is a regular heart rate, is this one in the bottom. So it's 1,500 divided by the number of small boxes, okay? And then the third method is this one on the right side. Whenever you have just irregular rhythm is the one that you're going to use. Basically, you count your R waves or your QRS complexes in the 10-second strip, and you're going to multiply it times 6 because that means this is what would happen in 60 seconds. The example that they are giving here is 9 beats in 10 seconds. You multiply times 6, and it's going to be 154 beats per minute, okay? Only use that one for irregular rhythms, the other two for the regular rhythms. Okay, now I was saying that we're going to focus mostly on the normal sinus rhythm today. So, meaning this is the definition. Basically, you will have a heart rate in between 60 to 100 beats per minute. There will be a P wave before every QRS, a QRS after each P wave. The RR interval should be regular, and then the P waves should be positive in lead 1 and 2. Meanwhile, the PR interval should remain constant. Okay, so meaning the PP interval will also be regular, and the interval should be between 120 to 200 milliseconds. So that way you can say this is normal sinus. Okay, so now we're going to go through the waves, intervals, and segments. Okay, so I was going to share new screen, the whiteboard. Just coming back to that, then for the axis, we're going to talk about it in a little bit, but going to the waves. So the P waves, there are two things that you're going to look at. Okay, you're going to look at two leads. So you're going to look at lead 2, right? 1 second. So we're going to look at lead 2 and lead V1. Okay, so in a normal, or at least sinus P wave, the P wave would be positive, completely positive in lead 2, and meanwhile it's going to be biphasic in V1. I know Luca also touched a little bit about this, but in general, what you need to remember is that because lead 2 is actually at 60 degrees and the HR depolarizing towards it, both of the HR depolarizing towards lead 2, then you only see the depolarization of the HR as something positive. Meanwhile, V1, as you know, by location, is on the right side of the chest. So V1, you will see the depolarization of the right atrium as positive and of the left atrium as negative. And that's why it's biphasic, okay? But for you to know that the P wave is coming from the sinus node, this is how you're going to state it is from the sinus, okay? Now, it also tells you the P wave when there is left atrial enlargement and when there is right atrial enlargement, okay? So for left atrial enlargement, the best thing that you can see is V1. Why? Because you will see that the LA portion will be wider and it will last longer, okay? The criteria for you to say is left atrial enlargement is going to be greater or equal than 1 small box, okay? Of both duration and how negative this portion is, okay? For right atrial enlargement, which is also called P pulmonale, you're gonna see a very tall P wave in lead 2, okay? By very tall, I mean greater or equal than 2.5 millimeters, okay? So 0.25 millivolts. So remember how the P wave is in sinus and how the P wave will look in when it's enlarged, okay? So we're going to go back now to this, let me see. So I talk about the axis for a little bit. So the axis, it's very important also to remember that there are only two leads that you're going to look at for the axis. Okay, so you're going to look at 1 and 2. You can see that 1 is at 0 degrees. This one you need to remember, you need to memorize where each lead is. Okay, so 1, 2, and 3 is going to be 0, 60, and 120. Meanwhile, in the augmented leads, you have AVL at -30, AVF at +90, and then AVR at -150. Important concepts to remember is that each one of them has a perpendicular, meaning each one of them has one lead that is 90 degrees away from each other. So the perpendicular lead to lead 1 is AVF. Why? Because it's 1 is 0 and AVF is 90, okay? And so on. So AVL with 2 and 3 with AVR, okay? So the normal axis, the definition is actually from -30 to +90, and that's important because a lot of textbooks in physiology will tell you from 0 to +90, and it's not the case. Also, -30 to 0 is normal. Okay, so remember, -30 to +90 is the normal QRS. As I was saying before, in general, the direction of the current will be from negative to positive, and most importantly, whenever something is depolarizing toward one of the leads, that will be recorded as something positive. In this example, you can see that the direction of the current is going from left to right, There is a lead on the right side of the screen and another lead in the left side of the screen. So you can see that the left one will show us a negative deflection. Meanwhile, the one on the right, because the current is going towards it, it's going to be positive. And if there is a lead right in between, meaning 90 degrees away from the direction of the current, you will see it as an isobiphasic lead, meaning the same amount positive and the same amount negative. Okay, so this is just an example to tell you that in axis-wise, obviously there are T-wave inversions here, but I just want you to look at the axis so you can see that lead 2 is pretty much isobiphasic. Okay, so that means equally positive and negative. So you go to your perpendicular from it. Okay, so lead 2 is at 60 degrees, the perpendicular is AVL. You see AVL is completely positive. That means that the actual axis is going towards minus 30. Okay, it's pretty much the same. And so if somebody ever asks you, does this patient has normal axis, or if the question is, does this qualify for left axis or right axis deviation, you're just going to look at 2 leads. Okay, remember for P waves, we said that we're going to look at lead 2 and V1. For QRS axis, you're going to look at lead 1 and lead 2. You can see here in this example, it's telling you that whatever comes in between plus 90 and minus 90, meaning towards the left of the patient, will be reported as something positive in lead 1. Okay, whatever is away from that is going to be reported in lead 1 as negative. In lead 2, as it's basically in another axis, another degree, I meant 60 degrees, you're going to see that this is going to have from minus 30 to plus 150, you're going to see positive deflection if the axis is within that range versus negative in the other range. Okay, so if a patient has QRS, the QRS complex being more positive than negative in lead 1 and also in lead 2, when you combine those two, you're going to see that it lands in the normal axis. So the conclusion from this is basically if it is positive in 1 and 2, the patient has a normal axis. Okay, so look at this again, it's the same. So if 1 is positive and 2 is positive, it's a normal QRS axis. But then if you see, for example, lead 2 positive with lead 1 negative, that would land in right axis deviation. Meanwhile, if 1 is positive and lead 2 is negative, that would land in left axis deviation. Okay, so it's a quick way, an accurate way to say normal axis, left axis, or right axis deviation. Okay, this is just more examples about how you're going to see a QRS complex. So depolarization-wise, this is actually just important in the QRS to remember that V1 has a small positive deflection at the beginning. Okay, the importance of that is that once you look for left bundle branch block, you're going to see that that is lost. So that septal depolarization happens from the left bundle, as you can see here, and it's happening from left to right, and that's the only time in V1 that you will see a positive deflection. Okay, the only time in a normal QRS axis. You will see it in pathologies like right bundle branch block and others. Okay, but remember that that initial depolarization of the septum is from left to right, and it's recorded in V1 as a small positive deflection. Okay, so let's see here. So let's do a little bit of cases, and then we'll go back to the. We can also annotate here actually. So let's see. So in this first case, okay, I don't know if anyone wants to jump in, but trying to do the actual order that we were talking about.
Just choose someone.
Just choose someone?
Yeah.
All right.
Take your pick.
So yeah, exactly. I'm trying to look at Juan.
Choose someone for him, Rafa. Don't make him choose.
Juan Arango. You can go. Tell me about it. Can you see the whole thing?
Yeah, I can see.
8-year-old male, no past medical history, presenting to your clinic for pre-employment visit.
Okay. So standardization seems.
Tell me what you're thinking about and all the things. I don't know if you're muted or muted. Cannot hear you.
Can you hear me?
Do you have
No, it seems that Rafa had.
Juan?
Can you do it again, Juan? Sorry.
Hear me?
Yeah, we can hear you now.
Yeah.
So standardization seems normal.
Okay, so as you saw, Juan already knows who the patient is. So he's talking about standardization based on this, right?
Yes.
So a rectangle that it's 2 big boxes, so that means 10 millimeters per millivolt. Okay, so at least you know that the amplitude, whatever conclusion he goes through amplitude, should be okay. Okay, go ahead.
And I just go for the heart rate. So I see 3, 4, 5. I see a heart rate of around 60 to 75.
Mm-hmm. So he's using probably the count-off method, as you know. So 1 big box, 2 big boxes, 3, 4, 5. So he's in between 5 and 4. So that's why he's saying 60 to 75 beats per minute. Okay, go ahead.
Then I'd say we have normal sinus rhythm. I see P's after every QRS.
So there is a P before a QRS, there is a QRS after each P wave. The only thing that doesn't really qualify to say normal sinus is the RR interval. If you measure here to here versus here to here, it's going to be a little bit longer in the second one that I'm pointing out. Okay, so this patient has a little bit of sinus arrhythmia. Right? So the definition is actually if it varies more than 10%, which it does. But overall, it's the sinus beat coming from the atrium. What else?
I then check the axis. So 1 and 2 are positive. So we have a normal axis.
Correct.
Oh, and I just remembered right now. So the EKG is, I'd say it's inappropriately.
Correct. Thank you.
EKG, PVR is
I
negative.
didn't want to interrupt you, but yeah, so what you needed to look for is positive P wave in 1, positive P wave in lead 2, the negative P wave in AVR, and negative also T wave in AVR. If you have all those things, then you're pretty much certain that this is well taken EKG. Okay. So what else? Now go through each one of the waves, right, and segments and all this. So I'll just do it for you, so that way we see all the cases that I have here. But basically, you see lead 2, we said that you need to make sure that it is positive, right? Then you want to see that lead V1, the P wave is biphasic, meaning a little bit positive, a little bit negative, okay? Then otherwise you can state right away that there's no signs of atrial enlargement based on what I told you. Then you want to see that the PR interval lands in between 120 and 200 milliseconds, meaning 3 small boxes to 5 small boxes, which is the case, right? It's around 3 to 4 boxes, so it's a normal PR, and it's constant, right? So it's part of that I was telling you to say that the rhythm is completely normal. Afterwards, as I was mentioning in that slide, the PR segment is another thing that I look at, because the PR segment is important for you to diagnose acute pericarditis, right? So if you remember, the definition of it is going to be like diffuse ST elevation in the EKG with PR depressions being seen, okay? Not necessarily they will be there, but they can help you a lot because they are specific for it, okay? Now, the next thing was the QRS. You already covered the axis, obviously. Besides that, we'll go through some of the things for you to tell you if this is LVH or RVH or all these things, and if not, in another session. But then you also want to see how the progression of the R wave is. So the normal thing is that from V1 to V5, you'll see how the R will be continuously getting bigger, right? The transition from R to S being more than 1, meaning that the R is higher than the S depth, is going to be between 3 and 4. That's the normal, okay? And then usually from V5 to V6, either it maintains the amplitude or it goes a little bit lower, but that's the normal, okay? Now, after that, you see your J point, which is, as the name says, is the junction point. It's the junction point in between the QRS and the ST segment, okay? So that is important because that's where you measure if there is ST elevation, ST depression, and from there you check your ST, meaning if it is elevated or depressed, you're going to see if it is upslope and downslope and if it is straight. All of those are different and important to differentiate once you're talking about if this is ischemic or not. Okay. And after that, you're going to see your T waves. So your T waves should be always upright except for V1. Okay, you're going to see a negative, and AVR, you're going to see a negative. That's the normal. Okay, unless the patient is less than 14 years old, but I'm not going to cover that because we're internal medicine, not peds, right? And then the QT, a very good way to assess it when the patient has a heart rate in between 60 to 100 beats per minute, meaning normal heart rate, right? Is to just check your RR interval and check how much your QT is percentage-wise, okay? If it is less than 50% or one half of your RR interval, then most likely your QT, independently of correction or not, is going to be normal, okay? That's a quick way to do it. If somebody is asking you to actually calculate it, there are formulas, right? Bassett formula, Friederica formula, we'll cover it some other day probably, okay? And then afterwards, extra features, what I mean about that, it really depends on whatever there is. If you see like J waves or epsilon waves or any other stuff that will be covered later on, okay? And then if you compare with the prior one, likely this patient will have the same exact thing. This is a pretty normal EKG, okay? There's only sinus arrhythmia, which is a normal finding in someone who is young, okay? So let me just draw in. Okay. So now how do I erase all this? Clear. Yeah. Thank you. All right. So let's go through here. So we already covered this. I'm not going to cover it again because I also want you to see as many EKGs as you can. Okay, QRS wise. So this is just like these slides that you see. You can screenshot them or anything. I think they will upload. But in general, it's just a fresh reminder for you to know what are the normal findings and values, the QRS axis, the P wave, how much you measure, PR segment, as I'm saying here, is very important that it is isoelectric. And remember, this is very important. The isoelectric line is actually your TP segment. So if you go back to this EKG, TP is in between the T wave and the start of the P wave. Okay, that's your actual isoelectric line, and that's what you're going to compare everything else to. Okay, your ST and your PR and all these things. Okay, then otherwise, as I was saying, T waves should be positive, exception AVR and V1. Okay, the QT cutoffs and stuff, you can see it later. Okay, so let's see another example. Let me see if I know anyone else. I met Nadim yet. No, I haven't met Nadim. I think it's
someone with the camera off.
All right, someone with the camera off to see if they are here. Tony, I don't know. Tony, let's just do Tony.
Yes, you did meet me.
I met Tony yesterday. I don't know.
Yes, you did. I'll put on my camera.
Your time to shine, Tony.
Yeah.
Yeah. Okay. First of all, in 2 and 3, there is a. Oh no, I don't see any P waves.
That's important. Yeah. So we'll get to rhythm. So let's go together into this. Okay. So basically, you want to see who's your patient, right? So that's the first thing. So you can see that the patient has a lot of comorbidities and already has known heart failure with reduced ejection fraction, a CVA, somebody who has a lot of things going on already, okay? So that way you're already a little bit biased, but at the same time, you know what you're going to look for, okay? She's presenting with palpitations, so you're going to look mostly to see the rhythm, right? Afterwards, you're going to see if it is well taken. I mean, that's standardization first, right? So you see there's 2 big boxes. of amplitude, so that tells you that at least the voltage is standardized well. And then you're going to see if it is well taken or not. You don't see P waves, as you said, but at least you can say that the T waves are negative in AVR, so most likely it's well taken, right?
Mhm.
Now, as you were saying right now about the rhythm, so things that you look for sinus rhythm are going to be like discernible P waves that are basically positive in 1 and 2. You're going to look for RR interval is regular. All of this is like not really that, right? So right away you can see that this is a very irregular rhythm. So the first thing when you're looking at someone and you're looking for a tachyarrhythmia is to differentiate if this is narrow complex or wide complex. So that's why I was giving a refresher there of what's the normal QRS duration, right? Normal is like 60 to 100 milliseconds, up to 110 milliseconds. You can say it's also narrow. So let's say less than 120 milliseconds is narrow. So in this case, if you count, it's around 2 small boxes. So that's 80 milliseconds. So that then you know that it is a narrow complex attack, right? And then the only thing that I want you to know for now is that after differentiating is if it is wide complex versus narrow complex, is to differentiate if this is regular or irregular. Okay. So what do you think about the regularity of this, Tony?
I think it's irregular.
Yeah. So which ones do you remember that are tachyarrhythmias that give you an irregular narrow complex tachyarrhythmia?
The SVTs.
So the only way that that would happen would be if there is something making it irregular. So let's just, as a refresher here, we're going to say then, so narrow complex tachy, okay? If it is irregular, think about 4 things, okay? The most important one, which is what the patient has, is AFib, okay? Then think about multifocal atrial attack, okay? Usually in the steps, it will present as a COPD exacerbation who is hypoxemic, and they do an EKG, and then you see 3 or more P-wave morphologies, right? Then you're going to think about also with sinus, with PACs, okay? And then last but not least is going to be atrial flutter, which the flutter is actually very regular, but if the AB block is variable, AB conduction is variable, then it will give you this, okay? So always keep those into your mind when you see something like this. But in general, what I wanted you to know is how a rhythm that you will see a lot will present, and this is AFib, so irregular narrow complex attack. Okay. So the next one, a great job. Let me see here. At some point, I'll get better with this. Sorry.
It's not great.
Not.
Just another next. You can just try to do undo for all of them. Eraser. We're gonna send it on there.
Okay. At some point, this will go away, I guess. Well, actually, it's only erasing the ones from before. You just might be because it's on top of the slide right away. We'll see once I go out of here.
Yeah, that's what I'm saying. I'm doing like next slide.
Yep. Okay. So AFib, right? Now this one is just I'm just going to go through it. I just wanted you to see how it differently looks again, something that is completely opposite of normal sinus. Okay, so again, you have a patient with acute compensatory heart failure. In this case, you cannot really assess much more than saying it is the voltage is the one that is well standardized. The T wave is negative in AVR, so you're assuming it's well taken, and then you see how wide complex tachycardia goes. Okay, so this is definitely more than 110 milliseconds, and it is regular. Okay, So a patient that presents to you like this in the CCU, you have to think VTAC, okay? You will receive another lecture about that, but in general, you will think about VTAC. Always treat as VTAC unless you have the diagnosis made by someone with more experience, okay? So how about this one? Let's see, this one can ask someone.
Another one with the camera off or camera?
Camera off, camera off.
Camera off. Let's see. Let's go. Let's go. Let's scroll.
Okay, Eduardo Perez. He's asking.
Hello.
Hey,
Anyway, see, people is there.
people are there.
Yeah.
Trust but verify.
Eduardo, next time.
Yeah.
I am unable to turn on my camera right now, but that's okay. So start with the person. They have chest pain. Great. Very informative. I usually start with rate, I guess. So this is really odd. So give me 1 second. 300, 150, 100. It's about 90-ish, I would say.
Mhm.
Um,
Yeah, he was using an account method. Okay.
yeah, because it looks regular to me. So
Yeah.
I'd say.
I agree. Yeah.
And then I see normal sinus waves in 1, positive sinus. Sorry, yeah, P waves, yeah. In 1, the P waves are normal, and in 2 as well. And in AVR, they are bimodal, kind of ish, maybe a little larger for.
Yeah, in AVR they are mostly negative. Yeah. I agree.
Yeah.
And I mean the table you cannot really see it well because it's fused with whatever is happening there that you'll get to. But
Right.
yeah, I would say it's well taken. Yeah. And then you were also talking about P waves in general, so it was positive.
Yeah, and it is sinus rhythm because there's P waves before every complex, so that's good. And then when we get to the actual QRS, so the PR length is normal. The QRS is extremely wide. I don't know if this is. I feel like this isn't just a QRS. I think it's like eating the T wave.
Exactly. You can see here how everything is getting merged. And I think that the best one that you should always look at all the leads when this happens because you're not really sure where the QRS ends, right?
Yeah.
Where you're basically ST will start, which is why it's very important to always look into where is my J point, right? So the junction. So if you see V1, it's actually, you can see that it's actually narrow.
Right. Oh, there it is. Yeah.
So if you trace that down, because obviously everything is happening at the same time, basically I'm sorry, I have essential tremor as anyone could see there. So basically you can see that the QRS is ending in a normal QRS duration, but then your junction point, J point, is happening very elevated in these leads that I'm hearing from V1 to actually V6, okay? And since then, you're starting to have a ST segment, which is, in some of them is straight, in some of them is sloping, and some of them down sloping, but the degree of elevation is quite a lot, right? So anyone remembers about locations? Where would you say, if you don't know, Eduardo, it's fine, but if you know, you can go ahead and tell me, where would you say?
I'm gonna say anterior, like LAD, just because it's like right at V2, V3, V4.
So basically, well, this is like diffusely here, right? But in general, you say V1 and V2 is going to be septal wall, okay?
Yeah.
V3 and V4 are going to be anterior wall, okay? V5, V6 is going to be lateral wall, okay? Now in the limb leads, 1 in AVL is going to be lateral wall, okay? And then the inferior wall is going to be 2, 3 AVL. But those are actually having ST depressions. Now, if you see this EKG, would you say this is an ST elevation MI of anterolateral wall, or would you say this is a non-ST elevation of the inferior wall? What would you say?
I would say ST elevation of the anterior wall.
Correct. Correct.
Yeah.
Why is ST depressed in the inferior leads then?
Because why is it depressed in the inferior? Because it's increased in the anterior. I
So
don't
yeah,
know.
exactly. There is ST elevation in a wall. You usually will see reciprocal changes, right?
Yeah.
That's how we call it, in the wall that is opposite. So because the anterior wall is elevated, then you'll see ST depressions in the other ones. Okay.
Mhm.
So let's see.
Oh yeah, and I forgot access. Sorry, going back to
Don't
the
worry. I mean,
beginning.
in general, as I was
Yeah.
telling you, as long as you go through it in your mind, it's
Nice.
So this is what I was saying. I mean, we can go through how an ST elevation occurs. In general, it's very progressive. It goes at the beginning. You actually only see hyperacute T waves. It's not depicted here, but you can see like hyperacute T waves, front base, and then you see ST elevation, and then it develops a Q wave. Usually, when a Q wave is already developing, that means that it's around like 12 hours that the patient has been having the event. Okay, and you see how it would progress if you don't do anything. Okay, so in the end, it would end up with Q wave. Okay. So I'm not going to go through that, but what is important here though is how do you call that it is ST elevation? Okay, so 1 millimeter is your cutoff to say it is a ST elevation, but the exception is going to be V2 and V3. That's very important, and as I'm pointing out here, it depends on the age and sex. Okay, so for women, independently of the age, it's going to be 1.5 millimeters in V2 and V3. If you remember that first EKG that I showed you, that guy with 28 years old had some ST elevation in V2 and V3, but it was way less than 2.5 millimeters. So that's why I didn't mention it as something wrong, because that's actually normal. Okay, so in men less than 40 years old, 2.5 millimeters, and men more than 40 years old, 2 millimeters. And this is what we were saying about location. I think this is the best slide for that. So anterior or anteroseptal wall V1 to V4, lateral wall 1 AVL V5 V6, and inferior wall 2 3 AVF. And as Eduardo was mentioning right now, he was actually pointing out that what's the actual artery that is occluded, right? So he was pointing out that the LAD territory was the one affected, and he was completely right. So V1 to V4 is going to be your anterior wall, which is always by the LAD. Now, as you can see, it can also be at diagonals go to the lateral wall, and that's why this patient in particular had basically an ST elevation in all those leads. Okay, I see this one. Sharel, just turn right away. Tell me what you think. How would you go through it?
So this is a 67-year-old male with hypertensive urgency. So the first thing that we have to look is the voltage. That seems to be normal.
Mm-hmm.
Then we're gonna check first if we can see the rate. So in this case, it seems to be the heart rate, let me check, 300, 150, 100, between like 60 and 75.
Mm-hmm. A little bit more towards 75, but yeah, I mean,
It's gonna be like probably like 70.
Yeah.
Then we're gonna have to, the next thing we're gonna have to see the P. We can see, for example, in D1, we can see the P before the QRS, also in D2, the P before the QRS. Then we can see the PT that seems to be normal. The rate seems to be regular rate since the seems to be regular.
Mm-hmm.
Then we can check the axis. So in this case, I would say, yeah, we see like isophacic, basic in D2, so it's gonna be like normal axis.
So just pointing out to that. So if you see when somebody is saying that it's isobiphasic, that means exactly the same positive than negative. Okay.
Mm-hmm.
It's not the case here. It's more positive.
Oh yeah. Yeah, you're
So
right.
the only thing that you want to see if it is more positive than negative, basically.
And negative. Mm-hmm.
It is. So it's a normal axis, right?
Mm-hmm.
Okay. Anything else in general that you want to point out?
What I can see, for example, in B5, B6, I can see the T wave is negative. And also the QRS seems to be increased. That could really be related like with hypertrophic changes since he's hypertensive.
Great, exactly. Yeah, so that's why it's important to know who's your patient, right? Because you know what you're going to look for. Okay, so patient who comes with hypertensive urgency likely has had hypertension for a long time, so you are going to look for several things, but in general, you're also going to look for LVH, right? So basically, you know who's your patient, you see your standardization, you see if it is well taken or not, and somebody could tell me here, oh, but the T wave is positive in AVR. As I told you, there are some exceptions, and this is one of them. But in general, you're going to look for, after going through the whole thing, this is sinus rhythm, obviously, you're going to look for here in this EKG in particular, criteria for LVH. There are several criteria, I'm just going to name them. Okay, so Sokolov is one of the ones that you will use the most. You will use Cornell criteria as well. There's also Peguero criteria, and there's the Rongill Estes point system. Okay. But in general, when you see LVH and then you see T waves inverted here, anyone would be concerned that this is ischemia, yes or no?
No, in this case, no, because what I see is that T wave is very symmetric.
It's
So,
actually asymmetric. So,
oh yeah, it's asymmetric. So if it's symmetric, will be like ischemia.
yeah, so I agree with you. Obviously, the thing is that in general, you still need to rule it out. But in this case, definitely this is not ischemic type of T wave, okay? But in general, in real life, you will still have to like check troponin, trended, and all these things, right? But looking at this EKG alone, you wouldn't be thinking this is actually ischemia. And as you were saying, it's asymmetric and it's related to LVH. So this is the typical pattern is called LVH with strain, okay? Strain pattern, which is seen in the lateral leads where the voltage is the highest, okay? So V5, V6, 1 and AVL. So I have time for one more.
One more. Yeah, we
Yeah.
will.
All right, so this one you will see several times while, especially if you're rotating cardiology, because this is a typical EKG that ED will freak out and call you right away. Okay, so in any console cardiology, you will see it. So let me see now. I'm just going to pick Julia, but I think I can't. Noble, I know Noble. Noble?
No.
Are you there? Okay.
Yeah, hey,
Yeah, okay, great.
Hey.
How are you? So
I'm good. Yeah.
let's
So-
see if you can tell me a little bit about this EKG. And again, just go general, maybe the first 3 steps, always do them.
Yeah.
Okay.
Sure. So this is a person with 48-year-old female, which comes with chest pain. So standardization next. So I see the voltage is too big box, so that's good. And then I can see P wave 1 and 2 upright, and then in the AVR is P wave negative, and T wave is also negative. Yeah, so that's after that rhythm. So it's look like rhythm is regular, and then rate it's about 4 big box, so about 75.
Mhm.
Other than axis 1 and 2 both are positive, and on 2 it's like looks biphasic mostly.
Correct.
Yeah.
So
Uh,
when you see a biphasic one, you want to see the perpendiculars, right? Which is AVL. And that one is positive.
Positive. Okay.
So you will see that the axis is toward AVL, right?
Mhm.
So it's minus 30 degrees, still within normal.
Okay.
What else do you see? That is, you can go through directly to the major thing because we're the last EKG, right?
Okay. So I see that in late 2 there's like ST depression, and also in from V2 to V6 as well there's like ST depression.
Yeah. Exactly. So definitely that ST and P wave, right? P wave is the most prominent thing. But in all precordial leads, basically, P wave inversion, okay? It's not that uncommon to see, but it's very important for you to keep it in mind that the first thing that you need to make sure that the patient doesn't have is something intracranial, such as subarachnoid hemorrhage, okay? So I'm just going to put here in a small box your differential diagnosis for this EKG, okay? So I'm going to say here, one is gonna be, well, ischemia, obviously, right? But this is what they call Wellens pattern B, okay? Let me just put this here. Then number two will be cerebral P wave, okay? Which is basically what I was telling you about subarachnoid hemorrhage. Then you have to think about also about stress cardiomyopathy. You have to think about apical hypertrophic cardiomyopathy. Okay? Then there's a fifth thing that can give you this, which is called cardiac memory, but you don't have to really know much about it. It's just RV pacing basically, and it's prolonged. It can give you this. But anyways, this EKG is very important for you to keep it in mind. Obviously, it can be ischemia, but then cerebral P wave, stress cardiomyopathy, and apical hypertrophic cardiomyopathy can also give you this. Okay, so we can go through more examples in another session, and whichever topic your chiefs would like me to do, I'll be available. Okay.
Yeah, feel free to reach out to Roberto personally, bother him in the hallways or anything like that. This lecture.
Yeah. Any EKG you want to send that looks nice, just send it to me. Definitely.
Yeah, and this lecture will be recorded. We'll upload it to the webpage. And thank you, Roberto, for your lecture. I think it's pretty useful. So for everyone else, we'll take a brief break. We'll be back at 4:05, where Maria is gonna present a very interesting afternoon report. And I'm gonna put up the QR code as well, so you can start logging into the session.
Thank you, everyone.